Hello, everyone. It's a webinar that is sponsored by Medtronic, and that is going to deal with some daily practice challenges. And so the idea is to learn more about contemporary TAVI practice and how to tailor the device to the anatomy of the patients. So to help me drive this conversation, and it has to be a conversation between you online, connected online, and the team here. And to help me, I have two of my very good friends, Yoe Hono, interventional cardiologist from Japan. Hi, Yoe.
Hi, everyone.
As well as another good friend of mine with a lot of experience about transcatheter aortic valve implantation, Mike Saji, also interventional cardiologist from Japan. Hi, Mike.
Hi, Didier. Thank you for introduction. I'm very happy to be here.
Okay, so welcome. So before we kick off this webinar, just let me remind you that this has to be interactive. This is really dedicated and built for you just to hold together, try to improve our experience and for the benefit of our patients to bring something back home. So you will see a QR code that is going to pop up. Please connect to the chat and send us any kind of comment that you have, any questions, remarks, concerns, and we will try to address these issues during this webinar. So what are the learning objectives? If we can see the slide. The learning objectives for this webinar are very simple. The first one is to try to understand and capture the challenges of TAVI in specific anatomies. And what we'll try to discuss all together today is how to try to tailor and match the anatomy of the patient to a specific device. And we're going to discuss the various platforms that we have and try to understand what could be more suited in two very daily life challenges. The first one being small aortic annulus, and the second one being a bicuspid aortic valve. So two real challenges for our practice. So I guess we can start. So remember to challenge us and to bring in your comments. But I will hand over to Mike. Mike is going to drive us through a case. Everything is going to be case-based. The first case is going to be a patient with a small aortic annulus. So Mike, the floor is yours.
Right. Can you give me a slide? All right, that's good. Right, thanks, Didier. My name is Mike Saji, Tohoku University Faculty of Medicine, Tokyo, and I'm going to present a case with a small and calcified valve. This is my disclosure. So the patient is 86-year-old lady with a past medical history of just a hypertension. And she has had a chest compression for 3 months and referred to our center. And she was considered a good candidate for transcatheter therapy, and a TAVI was planned. And she's a very small lady. The height is just 141 centimeter and 33 kilo, and BC was just 1.1. And she has mild frailty, and her lab suggests mild anemia and mild CKD and good nutrition. Right, and the EKG showed the normal sinus rhythm without the right bundle branch block. An echo showed the severe stenosis with a preserved ejection fraction, and the mean grade was 56. And it also showed the mild mitral stenosis. Mean grade was just 4.1, so leave it alone. And other than the severe stenosis and mitral stenosis, there's no other valvular disease. And in addition, there's a mid LV obstruction with a maximum gradient of 36, but there's no LVOT obstruction or SAM. So we will leave it alone too. And a coronary CT showed no coronary artery disease in the specific patient. And 3D CT suggests the feasible transfemoral approach. And 3D CT, when you focus on the aortic valve, there is LVOT calcification on the NCC. I'm sorry, there's a bulky calcification on NCC, and also there's a LVOT calcification, as you can see on the left side. And if you see the CT measurement, the parameter is 69.8, and the area was 374 millimeter square. And minimum diameter is 19.5 and maximum diameter 25.0. And the sinus of Valsalva width range from 26.7 to 27.5, relatively small sinus, I think. And also regarding the sinus height, it ranged from 60.3 to 17-ish. So these are or more than 50 millimeter is acceptable. And the coronary height, 12.5 for LCA and 14 millimeter for RCA. And the member septal length was 4.1 millimeter. And let me remind it a standard type of strategy in our center. And if you see the severe stenosis patients, and if there's a calcification or LVOT, and the bulky calcification or aortic valve, or a small annulus is specifically less than 430 millimeter square, and which I'll tell you in a moment. And the physician tend to choose the self-expanding valve. And if you decide to do the BAB before TAVR, the initial balloon size can be determined by the size of the minimum diameter or LVOT, inner diameter of the LVOT if there's a calcification. And if there's a moderate or severe palpable leak after the deployment of the valve, the balloon size can be reconsidered by the perimeter derived diameter or calcium burden, in addition to the minimum diameter of inner diameter. And let me briefly review the SMART trial. So this is a prospective RCT, including the 83 international site to investigate the severe stenosis patient with the small annulus, specifically the less than 430 millimeter square by CT, and the patient were split evenly to either the balloon expandable and the self-expandable valve. And the outcomes, the primary outcome is the composite of the mortality, disabling stroke, and rehospitalization due to heart failure. And the secondary endpoint was the biparothetic valve dysfunction at 12 months. Although there's no difference in primary endpoint, the second endpoint, biparothetic valve dysfunction, has a huge difference, as you can see on the left side, and the self-expandable valve is a favor in terms of the hemodynamics. So in this specific patient, the strategy is as the following. So the TT-guided local anesthesia with the mild sedation from the transfemoral approach with a peptide catheter from the right radial artery. And before the deployment of the valve, we decided to do the BAB with a 20 millimeter inner balloon adjusted to 18 millimeter because of the size adjustable balloon, and also the benefit of the no rapid pacing requirement. And the deployed valve is, so we decided to deploy the 26 millimeter Evolt FX because of the small annulus and LVOT calcification, and no worry for the coronary access because there's no coronary artery disease in this specific patient. So the CT measurement showed a pretty deep chiasm overlap view, which is not visible or when you consider the camera angle. So we need to adjust that. But other than that, coplanar view, LO view is relatively shallower and pretty visible for the procedure. And chiasm overlap view, this is a pretty famous view, and it is validated for valve deployment. But however, it may be different from the view for the better assessing the behavior of the calcification or balloon dilation during the VAB. We just proposed the view for the better assessing the behavior of the calcification or balloon dilation during VAB before TAVI, which can be different from the chiasm overlap view. And it's important to visualize the target calcium next to the balloon during the VAB for safe and effective VAB. And since the chiasm overlap is pretty a steep angle, and when you look at the coplanar view, you can clearly visualize the calcium in this specific view. So we decided to do the VAB in this view. So as you can see on the left side of the screen, the 20 inner balloon was adjusted to 18 millimeter, and the coplanar view could clearly visualize the inner dilation, and also in a way adequately lift up the calcium. And the calcium lifted up, come back to the annual level after the deflation of the balloon. And finally, the calcium does not impinge the sinus of Valsalva. And regarding the deployment, we used the near, it's called so-called the near chiasm overlap view with a little bit shallower RL 30 and the caudal 30. And we positioned the valve and started to deploy the valve. And the depth looks okay. So we went to the LAO view and checked the depth, probably the 3 or 4 millimeter, which is acceptable. And release the valve, as you can see on the right, without popping out the valve. And also the expansion looks good. And this is a final angiogram, show the minimal PBL, good device position. And also the hemodynamics is ideal. The hemodynamics measurement showed the gradient just 4 millimeter mercury. And also the EKG showed no AV block after the procedure. So patient finally discharged with that complication in a few days. So this is a summary that our heart team decided to have an aortic FX valve in such patient with a symptomatic AS with a small calcified valve. The VAB was carefully done using the so-called calcified calcium-focused perpendicular view for better assessing the behavior of the calcium and the inner balloon. And the 26 aortic FX valve optimal deployment is expected to have a greater hemodynamics than balloon manual valve and will facilitate a greater valve durability for a long time. Thank you very much. This is my last presentation. Last slide.
Thank you very much, Mike. That was a very first interesting case with new techniques that we can implement in our contemporary practice, and maybe we're going to discuss that. And but the very first question that I would like to ask you both, and starting with you, Mike, given the challenges of this small aortic annulus, that is really one of the focus because it's been discussed based on the results of the SMART trial that may promote the use of a self-expanding supraannular platform in a very small aortic annuli. How would you summarize the main challenges when it comes to planning the procedure what are the complications that you could anticipate for a small aortic annulus for our friends who are not as experienced as you are in performing TAVI?
Right, thank you. So there are a couple of things. So initially, the small valve is more likely to have a residual grading higher. So the self-expanding valve has a benefit and this at this point. And also, the small annulus patient sometimes have a small sinus as well. And if you deploy the self-expanding valve, we have to be careful for the coronary access or coronary obstruction during the procedure. And specifically in Japanese population, I feel that the sinus is lower and also shallower. And that's what I think so far.
So thank you, Mike. So we understand the issue surrounding the hemodynamics. We're going to develop that afterwards, and also, as well as coronary obstruction. Yue, do you have any thought about the potential risk of annular rupture or aortic root injury? Because we saw in the case of Mike that that calcium could potentially impact the sinus of Valsalva. So is it still a remaining issue of small aortic annuli, that risk of aortic annular rupture?
Thanks, Didier. This is also important topics. And as Mike nicely showed in his case, a very typical case that we face in the daily clinical practice, these kind of anatomies can be combined with bulky annular calcification as well as significant LVOT calcification, which with contemporary devices compared to the previous device has lower risk of annular injury, I would say. But still, these kind of nasty calcification could carry risk for aortic root injury, which could be quite devastating outcome for the patient. So we need to avoid that kind of complication. So we need a very careful planning in this kind of patients.
So thank you, Yue, quite clear. If I come back to you, Mike, and your patient, we've seen that this patient had bulky calcification, but as it is quite frequent in a female patient, it's a combination of a lot of fibrosis and some calcium. And so we saw your technique of BAV. Could you just summarize it once again to make it clearer in terms of identifying the CT scan projection and what you do to select the appropriate balloon size for that BAV?
All right, thank you. So the Casper overlap is very famous view. So everybody knows the Casper overlap, but it's not for BAV. It's for deployment angle. And if you don't care the angle for BAV, sometimes the target, the very bulky calcification, is in the shadow of the balloon. And in that case, you cannot assess the balloon lift up, whether the calcium lift up or the calcium balloon is fully dilated or not. And if the assessment is inadequate, sometimes we deploy the valve with the under-expansion of the valve. So the self-expanding valve has a very weaker radial force. So before that, we need a good BAV. And good BAV require a good assessment of the balloon dilation.
Okay, so thank you, Mike. So let's now dive more into details about the hemodynamics, the potential differences in durability in this particular subset, once again, of small aortic annulus. And there is a quite interesting question from Hamed Zaran, who is connected online. We saw that you treated your patient with a self-expanding supraannular platform with quite small sinus of Valsalva. And the question for Hamed is, what is the impact on the feasibility of redo procedure in the future? So, Mike, do you have any view on that?
That's right. That's one of the weak point of the self-expanding valve so far. So due to the design of the valve, if you do put the same valve in the same position, probably cannot access the coronary again. But fortunately, in this specific patient, there's no coronary disease so far. So we decided to do the TAVI with the self-expanding valve. But that's one of the big problem.
Yeah, it's true that we have to integrate that the risk of the need for a redo procedure, and it has to be correlated to the life expectancy of the patient. So if we take a large US series of patients, when you reach 80 years, your life expectancy is somewhere around 8 years. So this has to be put into a perspective with the durability of the device that we use and the potential need for a reduced procedure. But from what I understand from you, Mike, is that the higher we get with these devices, potentially the more difficult and the higher is going to be the risk of sinus sequestration and
That's right.
to access the coronary. So potentially we will have leaflet splitting devices in the future that may help as well. Yoe, if we come back to the durability and hemodynamics, when Mike showcased a couple of slides from the SMART trial, that is a very important trial that generated a lot of discussion this year, and it's going to continue because patients will be followed up for 5 years. We saw in SMART a difference in terms of hemodynamic performance, really in favor of the self-expanding supraannular platform in small aortic annulus, but at 1 year without any difference in terms of hard clinical endpoints, death, stroke, rehospitalization. So do you believe that we're going to see a separation of the curves? And if so, when do you expect it to occur?
Yeah, thanks, Didier. This is an extremely important question, and everybody wants to know the answer, actually. What we can learn from the previous literature is that all of those durability studies, including long-term impact of, let's say, severe patient-prosthesis mismatch, we need a longer observation period. That's for sure. And usually, this hemodynamic impact has a potential impact on outcome at least after 3 or 4 years. So, as Didier nicely mentioned, as a primary investigator of this important clinical trial, I would say we need to wait and see for at least 3, 4 years, and hope. I think this initial big significant impact will translate to clinical outcome because we already have the data regarding this hemodynamic and structural valve deterioration. One study shows that the pooled analysis from the TAVI and all those other randomized controlled trials show that these uh, structural valve deterioration, clinical hemodynamic impacts, clinical outcome. It carries a risk for heart failure and all-cause death as a hazard ratio of around 2. So 2 times higher risk of these kind of clinical events. So we will see in the long run.
And yeah, you're right. And hopefully the 5 years follow-up is going to give an answer. We need that. We need that just to improve our practice and to see if it translates into mortality or stroke or something else.
Absolutely.
Mike, I have a question for you. We come back to your patient. And the question is coming from the audience, and Hamed is asking if you have any tips and tricks to prevent pop-up in such a small aortic annulus, despite the fact that you did a proper BAV. So you are very high, and we could see that there was a kind of blow some effect of the stent frame within the sinuses because you had a high position. It was not a tubular. The sinus were large enough just to prevent coronary obstruction. So what are the tips and tricks that you use to get a high implant and avoid pop-up in these small aortic annulus?
Right. Thanks, Didier. So compare the previous version of the device, the FX device is less likely to have a pop-up. But in my clinical practice, I little bit push in just a little bit. not to have a pop-up. This is one of the tips and tricks. And also, in patient selection, in my experience, if there's a lot of calcification, the patient is less likely to pop up. We need to be careful for less calcified valve. It's possible to have a pop-up. And also, when you look at the sinus, the ascending aorta, sometimes I saw the finding that the top device
Yeah.
can touch the ascending aorta, and they also prevent the pop-up, I think. So I think that also the good BAB also one of the tip not to have a pop-up. And once you need the post dilation, it's more likely to have a pop-up. So I try not to do the post dilation.
Okay. So it's a kind of combination of pre-deal, making sure that you apply significant force on the device just to keep it at target. And if you have interaction with the ascending aorta, it's also a preventive measure. So maybe I'm going to stay with you, Mike, for one question regarding coronary assessment, because making sure that the patients don't have, apart from the risk of coronary obstruction, that they don't have any coronary disease is part of the assessment. And we saw here that you only gave us some CT scan assessment. So do you use CT scan for the coronary arteries pathology assessment for every single case, or do you tailor to the patient? A younger patient, maybe you do that. More older patient, you do something else, or do you use CT scan systematically for coronary assessment?
Yeah. So right. Thanks. So in my clinical practice, anyway, the patient requires CT, gated ECG, gated CT. So initially we get a CT, and if there's a suspected coronary artery stenosis, I'll send the patient to cath lab and get a CAG. But if there's no obvious coronary artery disease, and also the patient doesn't have a angina symptom, I don't do the coronary angiogram recently. But 3 years ago, I did it, but recently, no. What about your experience, Didier?
So I was asking that because in our practice we are still doing the coronary angiogram. So maybe we need to move forward.
Oh, really?
It's because when we are still dealing with a whole patients with a lot of calcification sometimes, and when you get calcium, for the time being, we found it difficult to really analyze and make sure that you don't have any disease, significant disease. So for proximal vessels, I think it's very useful, but we are all learning together. So I guess I will try to get rid of that coronary angiogram and to rely more and more on CT. So Yue, are you doing the same? Full CT assessment for the coronary arteries, or sometimes do you still perform a coronary angiogram, a diagnostic one, before the procedure?
Oh, yeah, thanks, Didier. Actually, I'm in line with Mike's strategy that we do CT scan assessment in every single patient, but we also do the invasive coronary angio afterwards. I mean, after the implantation of the valve, in order to assess the feasibility of the coronary access, both for left and right, to see, after the tall valve, short valve, in which whether the commissure and coronary aligned valve is easier to access or not. So, kind of as part of the clinical practice and part of our recent clinical research.
Okay, so we understand that maybe it's going to become the systematic approach. So it means that you are quite confident in your ability to get a nice commissural alignment, and you have developed skills to get access to the coronary arteries. So it tells us that maybe we need to practice all together more and more to become familiar with that cannulation of the coronary arteries.
Absolutely.
Mike used the Evolute FX. But in the upcoming months, we will have even the FX Plus with a greater likelihood of easy cannulation of the coronary arteries. So that is very reassuring. So guys, that was a fantastic discussion. There are still a couple of questions coming from our friends connected remotely. So what I propose is that we move to the second part of the discussion with you, Yoe, with your case about a bicuspid aortic valve patient.
Sounds great. All right, so followed by Mike's great case, I would like to share my case regarding bicuspid aortic valve. How should we treat? So this is my conflict of interest. So the patient is 84 years male who had a recent history of acute decompensated heart failure admission. He also has a cardiovascular risk factor of hypertension, dyslipidemia, and reduced kidney function and chronic kidney disease stage 4. He presented with progressive dyspnea on exertion, NYHA class 3 symptom. However, he is independent with his daily living, not frail, clinical frail scale of 3, with body surface area of 1.5. The labs are shown here, decreased kidney function with eGFR of 23, elevated BNP level of 662. So this slide shows the coronary CT with no significant stenosis. As for the cardiac echo, the patient presented with very severe AS at peak velocity of 5 meters per second, mean pressure gradient of 63 millimeter mercury, aortic valve area of 0.5. This slide shows the aortic valve complex CT scan analysis. The annulus is shown on the left side. The perimeter is around 83 millimeters, quite large anatomy compared to the Mike's case. As for the sinus of Valsalva, it's quite typical that this bicuspid valve has asymmetrical sinus of Valsalva, and it's quite large. As you can see in the movie, in the right-hand side, there is a non-calcified raphe between the right and left coronary sinus. And you can see the very bulky and thick leaflet on the non-coronary sinus. So the LVOT size is more or less similar with the annular level. Ascending aorta size was 41 millimeters, not in the surgical intervention range. ST junction was nice and wide with 32 millimeters. As for the sinus of Valsalva, the height is sufficient. The left main height is 13.3 millimeters. As for the right coronary height, 17.3 millimeters. The aortic root angle is shown in the right-hand side, is slightly horizontal with an angle of nearly 60 degrees. As for the axis, as you can see on the left-hand side, the aorta of this patient is quite diseased with atherosclerotic change, especially in the aortic arch, otherwise unremarkable. So this illustrates the case summary of this patient. Area of 532, quite large, perimeter of 82.9. The diameter is 23.1 by 29.4, large and asymmetrical sinus of Valsalva with wide ST junction. As for the valve morphology, this patient has type 1 left and right non-calcified raphe, type 1 bicuspid aortic valve with severe bulky calcification in the non-coronary cusp. So based on the heart team discussion, the patient's age, elevated surgical risk, so on, our heart team decided to go for transfemoral TAVI with conscious sedation and followed by pre-dilatation with 22 millimeter balloon. We actually chose 29 millimeter evolute effects, although it was in the borderline range between 29 and 34 millimeter evolute valve. Since this is a very calcified bicuspid valve, we chose a smaller valve as in this case. So since the patient had severely diseased chronic kidney disease, we skipped the typical aortic root shot, but we placed two pigtails to define the perpendicular view, so-called coplanar view, as shown here. So first we placed two pigtails, one in the left, one in the non-coronary cusp, and define this coplanar line. And then the non-coronary cusp pigtail, we moved to the right coronary cusp. And we confirmed that this is a correct coplanar view. And then followed by balloon pre-dilatation with 22 millimeter balloon, very bulky calcification. We had a little bit of difficulty in the positioning of the balloon, but finally we were able to balloon. Look at this very bulky calcification and still has the indentation of the balloon, but we didn't want to make any aortic root injury. So this is the Evolut FX 29 millimeter valve as a first attempt. We intended to implant slightly higher in this specific case as shown in this right-hand side. This is the cusp overlap view of the first attempt. But we can appreciate it's a little bit too much high. Also in the LAO view, we thought that the valve position is too high as a first attempt. So we went on for recapture in order to implant the valve slightly lower than the initial attempt. This recapturing process should be done very carefully with a nice pacing, push and pull within the wire and the valve system. And we were able to achieve a very good position in this second attempt as shown here, both in the LAO view as well as the cusp overlap view. We wanted to place the valve in this appropriate position. And we went for the final release. We take time for this process to have some time for the valve to even more expand to achieve a very stable final release. And actually, it was a very good sealing with minimal PVL. There was no actually new onset conduction disturbance, narrow QRS, nice electrocardiogram pre and post. As for the hemodynamics, this is the invasive hemodynamics. We started with a mean pressure gradient of 53 in this specific case. And the final pressure gradient was single digit, 5, with a nice and wide separation at the diastolic pressure, which means there's no significant AR at this case. So post-procedure echo showed trivial PVL with mean pressure gradient of 5, effective orifice area of 2.1. So this shows the post-procedure CT scan. Since the patient had advanced kidney disease, we made a non-contrast CT. Although the patient had very severely calcified valve, the Evolut FX actually expanded quite well, as you can see here. And on top of that, we can appreciate that this patient had achieved nice commissural as well as coronary alignment. You can see that both the coronary arteries, left main and the right coronary artery, originates from actually in the middle of the commissure post, which facilitates coronary access. So actually, what does the data tell so far about the TAVI for bicuspid cohort? So this is a famous study, large cohort from TVT registry, uh, propensity matched propensity score matched pairs to 2,060 to 691 patients, both each in the bicuspid and tricuspid cohort. And it showed that as for the all-cause mortality, early and late outcome was comparable between the two groups. As for the stroke incidence, there was an early signal that in the bicuspid cohort had a higher incidence of stroke. However, as for the 12-month, there it was a comparable between the two groups. We know that there's several types of bicuspid morphology, and will this morphology impact the clinical outcome? And the answer is yes. So this is a nice study from my great friend Sohan Yoon. They looked at 1,034 CT confirmed bicuspid patients, mean age 74, SDS score of 3.7. And actually, the device used in this series was majority was Sapien 3, and followed by Evolut Pro, Evolut R, and the others. And as you can see in this nice illustration on the left side, uh, if the patient has calcified raphe or excess leaflet of calcification, very severely calcified leaflet, both combination had very poor clinical outcome compared to the less calcified anatomy. And I would like to finalize my talk with sharing this recent important clinical trial, which was presented in EuroPCR this year, followed by publication in a European Heart Journal. Actually, the previous studies that which I shared was a non-randomized trial, non-randomized study. And this was actually the first randomized trial for younger and low risk patients with severe tricuspid and bicuspid valve, which randomized with TAVI versus SAVR. And what the study showed, although it was relatively small number of patients enrolled in this study, both had more or less 180 patients each. As for the primary endpoint, death, stroke, or rehospitalization, uh, two arms, TAVI and surgery, was comparable. And as for the death or disabling stroke, statistically, there was no difference between the two groups. But if you look in the subgroup analysis for the tricuspid valve group and the bicuspid groups, the left hand shows the tricuspid cohort, which was actually comparable between the two treatment arms, TAVI and surgery. However, for the bicuspid cohort, although there's not significant statistically difference, there was a signal trend that event rate in the TAVI arm was higher, numerically higher compared to the surgical arm. So I would like to conclude my talk, ladies and gentlemen, dear colleagues and friends. Bicuspid aortic valve patients need thorough anatomical assessment in order to find the best solution for each patient, whether the treatment option should be TAVR or TAVI, and if TAVI is feasible, which type of device is even more optimal for the patient. And phenotype of bicuspid aortic valve, as I showed in my slide, can impact the clinical outcome. So we need a very careful look at it. And surgical aortic valve replacement still remains as a reasonable option for especially low risk and younger patients with bicuspid aortic valve. Thank you for your attention.
Thank you very much, Yue. This was a very interesting case, and you had some congratulations from our audience online, for example, Ben. So I guess we can start with the questions that have popped up from the online audience. So the first one is about the so we understand the challenges of bicuspid aortic valves with the risk of aortic root injury, malposition of the device, regurgitation, potentially stroke, misplacement of the device and so on. So it tells us that potentially there are patients who are not suitable candidates for TAVI, and you nicely stressed the importance of the phenotype and the combination of calcium and raphe. So if you had to provide an example, and I'm going to ask after yourself, Yoe, the same question to Mike. My question is, who, to your opinion, should still undergo surgery for a bicuspid aortic valves? We take the hypothesis that the patient is still operable. Which patient would you send to surgery?
Well, Didier, thank you for raising this important question. Actually, we still kind of struggle in our daily clinical practice with our heart team discussion, but it's a very important discussion, and it's the discussion is all for the patient better clinical outcome. So, as you mentioned, if the patient is operable, I would still consider surgery as a very good option. But as we learned from the previous literature and from our own experience, that outcome of the TAVI procedure is now very good with a contemporary device, let's say Evolut FX, and also in selected patients, Sapien would function well as well. So in order to avoid critical complication, as you mentioned, like root injury, root rupture, tamponade, so on, the calcification obviously plays a critical role. So if the patient has, I would like to repeat and echo the finding of that study, but if the patient has long, not only calcified raphe, the length of the raphe is quite important. If the length of raphe, even though if it's calcified, if it's relatively short, I would say it's a benign feature, but it's very calcified and long. I would say, let's say more than like more or less 10 millimeter in length. It obviously does not open up, and it precludes the expansion of the any kind of valve. And in that circumstance, the counterpart cusp's calcification is extremely important. So that's why the combination of calcified raphe and the calcified valve leaflets on the other side of the raphe, if they are combined, the outcome is really bad. So that kind of features I would definitely send to the surgery.
Thank you, Yoe. So let me go back to you now, Mike, with the same question, and maybe we can focus on the ascending aorta dimension. Do you integrate any aortopathy in your decision of surgery versus TAVI? And do you have a cutoff, a bicuspid aortic valve? Do you have a cutoff in mind, saying maybe it's not wise to put a device in this anatomy, or the aortic root should be repaired?
Right, thanks, City. So for the surgical perspective, 45 millimeters is a good cutoff sign for doing the aortic valve ascending aorta replacement with the AVR. But actually it really depends on the age. If the patient is pretty elderly, and if it's the ascending aorta is 50, we may be able to leave it alone. But yeah, so the patient is really, for example, the early 80 or 70s, we tend to send the patient to the surgery if there's a ascending aorta dilation.
Thank you very much. So this is quite clear. So I think we have addressed that question about the potential not really suitable candidates for TAVI. But we've seen, given the expanding literature on that phenotype, that subgroup that TAVI for bicuspid aortic valves with new generation TAVI devices works. We saw nicely with your post-assessment CT scan, Yoe, that we can get circularity. So now the key question, and that's one of the questions from Ben van der Branden, is what is the sizing that you use for bicuspid aortic valves? Let me start with you, Mike. how do you size for bicuspid aortic valves when it comes to TAVI?
Right. So the standard measurement is initially measure the annulus. Also we measure the measurement 4 mm above the annulus, and then decide the valve. And also I sometimes care the distribution of the calcification. As you has said, if the very bulky calcification of the NCC, the valves tend to go the other side, potentially resulting in the coronary obstruction. So, as Yohei presented, his case was a borderline between the 34 and 29, but I agree with the 29 because the potentially the calcification push to the other side of the non-coronary class. So that's my clinical practice. Did I answer the question?
Thank you. Yeah, nice. And so, Yohei, did you use the same for your patient, or do you have another algorithm in mind to size?
Yeah, thanks, Didier. So basically the same. Basically, we follow the annular based sizing, but I carefully take a look in the size of the LVOT as well. If it's similar with the annulus, or annulus and LVOT is almost more or less similar, we can, nicely and safely go with annular based sizing. If the LVOT is extremely large, and we sometimes see this kind of phenotype in bicuspid patients, in that kind of scenario, I carefully go for supraannular measurement. And why do we do supraannular measurement is that, as I showed in my post-TAVR CT scan, we learn from the post-TAVR patients, and we know that how the valve is expanded in this kind of anatomy. So we always know that the sealing of this valve happens in the level of more or less close to the raphe. So we kind of analyze a CT scan beforehand and see how the valve will expand potentially. And from that perspective, we tend to choose the valve. So basically, annular sizing, if it's in the borderline, as we discussed, I would go for a smaller size of valve selection.
And so, if I understand correctly, and that answers the question from our friend Ben, the Bavard sizing is mainly used by Mike, as we do, because we were part of the process of understanding the impact of that sizing methodology. And you integrate as well the LVOT shape, because it may impact to properly deploy the device at target. And I like it's very important to do as you did, apart from the Bavard algorithm with the annulus mean perimeter derived diameter, the commissure to commissure distance 4 mm above the annulus. I like the supraannular tracing, because here it was more a tapered configuration that we got for your patient. And moving to not a under dimension device, but it's just a proper sizing. You selected a 29, so there is still oversizing, but not an excessive oversizing. And that 29 was able to get circularity. If you put a 34 that is going to be more constrained, you may not expand the device appropriately. Circularity
Exactly.
to get to durability in the future. So I really like your advices, guys, about sizing. That remains central, apart from the features of the ascending aorta and the calcium in the device selection and the device size selection. So
one quick comment.
Yeah, please continue.
Yeah, Didier. You touched a very important point: the circularity of the valve. We know from the imaging study from Minneapolis that if the valve is not expanded or not non-circular, it carries a risk of halt, valve thrombosis, and it could translate to the less valve durability. So I think the circularity is key in this contemporary practice. Just a quick comment.
Excellent.
Yohei, is it
Please, Mike.
both balloon spinal band and cervical spinal valve?
Excuse me?
Is it any
Both valve,
both valve?
both valve.
Okay,
Yes, yes.
that's good to know.
It
Thank
was
you.
published in Circulation. Yes.
Yeah, and it's true that we observe more or less the same thing in Bavard. You can get good purpose circularity. So a quick comment from you, Yoe. One of the previous question that we applied for the case on the small annulus, but it's also the same for bicuspid, about the projection. In contemporary practice, what would be your recommendation in terms of working in the cusp overlap projection or the coplanar projection? Because we saw that you use the highs for landing the device appropriately to avoid the membranous, to remain in the area of the membranous septum. But let's imagine that we don't have access to ice. Cusp overlap versus coplanar. What is your practice?
Thank you, Didier, for another important point. I think type 0 bicuspid, type 1 bicuspid could be different. As for the type 1 bicuspid, I usually go with cusp overlap view. However, these bicuspid valves also often combines with very horizontal aorta that precludes for the appropriate true cusp overlap view projection. So in that kind of setting, I would not stick with cusp overlap view, rather stay with conventional LAO view and see the coaxiality of the device, the wire, and so that we can land both on non-coronary and left coronary side in the equal depth.
And a question for you, Mike. So we saw that you did the balloon pre-dilatation with your technique of the calcium, the projection that really isolate the calcium. The question from Hamed is about the speed of inflation of the balloon. Should we go for a fast inflation with a risk of not being able to control the movement of the calcium, or would you recommend a slower inflation of the balloon?
All right. So in my experience, fast expansion is more likely to have a rupture. So carefully, very slow inflation, but not too slow, because of the disruption, the blood flow. And in this specific balloon, it's called Inouye balloon. Doesn't require rapid pacing. So probably in a fifth second, we dilate the balloon and deflate the balloon, maybe 5 seconds.
And do you use the balloon angiography as a sizing methodology, or is it only for to see the movement of the calcium?
So after the deployment and the valve is underexpanded, we sometimes see the fluoro. Specifically, the RAO is a good view for assessing the underexpansion. So going to RAO and measure the bottom of the valve and see the TE as well, and assess the underexpansion or PVL and decide to do next.
So it comes back to your comment, Yoe, about the circularity. So Mike, it's a very important point. Assess the expansion in two orthogonal views. If you're using TOE, it's even easier. But we have to make sure that we get circularity. It's very important in contemporary practice, even for heavily calcified valve. So guys, once again, I really enjoyed discussing with you, and so is the audience. But we come to the end of this webinar. Maybe we need next time to double the duration of the webinar, because there are so many questions. But what I learned from our discussion on site and remotely online is that first we understand better about the challenges of small aortic annulus, namely mainly the hemodynamics, as well as the risk of annular rupture and the risk of sinus sequestration and coronary impairment. So it's very important to select the appropriate device, and we better understand now with the smart data. We need to wait for the follow-up, the impact and the importance of the potential impaired hemodynamics when it comes to selecting the proper device for the small aortic annulus patient. So we need to really integrate now the potential for a self-expanding platform in this particular scenario. The second thing that I also learned, it's bicuspid aortic valves. It remains a challenge, but we learned a lot during the last couple of years about sizing. we discussed that quite aggressively about the technical aspects. And Yoe, you provided once again a very interesting case with this repositioning. And we understand the apart from the hemodynamics, the importance of getting proper circularity with the pre-dilatation, proper expansion of the stent frame. If there is a need, as Mike said, for post-dilatation, we need to explore that with that two orthogonal views check of the stent frame expansion. So lots of remaining questions, but I do believe that we addressed a lot of them already during this very nice and very important webinar. So I'd like to thank you guys for providing us with your experience and helping me to address the questions from our friends remotely connected. So I wish you all a nice day. And if you want to continue to chat with Yoe, Mike, or myself, please feel free to contact us. Bye-bye, guys.
Bye-bye. See you in London.
Bye.
Yeah.